And as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. So let's resume our topic. That was the remaining part of Parkinson disease, and then we will move on our next topic, that is the schizophrenia. So point number one is about the Huntington's disease. It's a disease in which nerve cell, you can say, when nerve cell damage in the brain, and it causes drop in and GABA aminobutyric acid. This disease happens, and it is treated with the use of some drugs. Their name is tetrabenzene and resorpine. These are the two drugs which is used for the management of Huntington's disease, and it is due to the death of nerve cell in the brain. Point number two is the bromocriptine. It is used in the management of amenorrhea and galactorrhea. It's a repetition of previous point. Point number three is about the antimuscarinic drug that is used for the Parkinson's and disease and rigidity. Its example is benzaprine. Point number four is about the just and document that is known as PDR. PDR is not defined. Is its abbreviation is Physician's Desk Reference. It's a picture. You can say picture for easy identification of capsules, and it's you can see a manual which contain distinctive color combination that capsule can be easily identified. It also provides the manufacturer list. You can easily find it as a manual picture in the form of in you can say once you Google this PDR or physician desk reference, you will easily get its picture. It's just a guide for physician to for the easy identification of pharmaceutical products. Point number five, that is the summary of all drugs which we use for the management of Parkinson disease. Number one is about levodopa and carbidopa. As we discussed it in a detail, it has two formulation, that is the 25 by 100 mg and 25 by 250 mg. Its dose is TDS or QRD, or 3 times per day or 4 times per day. Second combination that is new is the levodopa carbidopa entacapone. Levodopa carbidopa is already discussed. Entacapone is a drug belong to the class of it's COMT, catechol-O-methyltransferase. It also help a key role for increasing the bioavailability of levodopa, or you can say dopamine in the brain, by avoiding its peripheral metabolism. It has three strengths: levodopa, carbidopa, and entacapone. I will let you know in the same sequence their strengths. Strength number one that is available, or you can say pharmaceutical preparation that is available, is the 50 mg levodopa, 12.5 mg carbidopa, and 200 mg entacapone. Similarly, 100 mg, 25 mg, 200 mg, and third strength is 150 mg, 37.5 mg, and 200 mg. This was all about the levodopa, carbidopa, and entacapone. Point number two about the summary is the dopamine agonist. Its example is the pramipexole, and its starting dose is 0.125 mg TDS, and double after 1 week and after another week, and further increase in daily dose by 0.75 mg weekly depends upon the response and tolerance. Most patients require 0.5 mg to 1.5 mg TDS doses. This is all about the pramipexole, that is the dopamine agonist. Next is the bromocriptine. Its dose is 7.5 mg to 30 mg for the management of Parkinson disease. And another example is the ropinirole. Point number, and by the way, this also comes under the dopaminergic agonist class. That is the pramipexole, bromocriptine, and ropinirole. These are the this comes under the dopaminergic agonists. Point number three is about the monoamine oxidase inhibitor. Its example is selagiline and rasagiline. Point number four is COMT, as I told you. Its example is entacapone and tolcapone. Point number five is about antimuscarinic agents that is used for the management of Parkinson disease. Its example is benztropine, piperidine, and orphanidrine, and procyclidine. Point number six is about the Huntington's disease. As I told you, this is a disease due to the death of neuron in brain, which causes drop in GABA. It is treated by the use of tetrabenzene and resorpine. And point number seven is about the About a syndrome that is defined as Tourette syndrome. It's a very difficult pronunciation for me. I hope you will get it. Tourette syndrome, and its example is pimazine, pimazid, and haloperidol. These two drugs are used for the management of this syndrome. It's actually a repetition of movement. Just to search for this name, you will find what's the syndrome. No, this was all about the Parkinson disease, and let's move on our next topic, that is this schizophrenia. Schizophrenia is a disease. It has an extremely variant prescription, and you can say in this disease, only minority shows violent behavior, and you can say there is a 10% patient which also commits suicide or also has suicidal thoughts, but majority of symptom falls in positive symptom range and negative symptom range. And example of positive symptom range is hallucination, delusion, and thought disturbances. And example of negative symptoms are apathy, like lack of interest, social withdrawal, and lack of motivation. Patient remains, as you can say, patient flow between these two symptoms, either stay in the positive symptom or either stay into the negative symptom. And the most problematic symptom is the negative symptom, and sometimes it doesn't respond, especially in the phase of remissions, when patient is moving from acute phase toward the between acute phase. Remissions period between the acute phase, when negative symptom appear, it causes more problem, and sometimes it doesn't respond to antipsychotic therapy. This was just a brief introduction of schizophrenia. Now I would like to let you know about two hypotheses about its treatment. Like what on the foundation on which our treatment basis hypothesis will actually define that direction. You know, there are serotonin receptor subtypes, that is the 5-HT2A and 5-HT2C. We use serotonin and LSD, that is the lysergic acid diethylamide, LSD and serotonin, for the management. Sorry, we don't use serotonin and LSD. When binds the receptor, it causes or stimulates hallucinogenic effects or hallucinogenic effect, or you can say positive symptoms or negative, as you can say schizophrenic symptom. So hypothesis tells that by blocking these receptors, we can achieve our pharmaceutical, or you can say therapeutic objective. Second hypothesis about the D2 receptor, that is the many antipsychotic drugs blocks D2 receptor at postsynaptic in CNS. So we get our pharmacotherapeutic objective by modulating these receptors, and patient comes out of schizophrenic condition. So this was just a brief introduction of schizophrenia and its our therapeutic planning foundations. So let's discuss our points. So point number one is about the these are a drug, a class that is known as phenothiazine. It contains typical psychotic drugs and atypical psychotic drugs. Later in points, I will let you know about all of its examples. So let's discuss its point. Number one is about one of its example is thioridazine. Its dose is 100 to 800 mg. Point here is that it causes least extrapyramidal side effect. So what is the extrapyramidal side effect? It's as you know, voluntary muscles or voluntary movement of our body remains in our control. When this went out of our control, happen in out of our control, this is defined as extrapyramidal side effects. And you can and there these drugs, one of the example of thioridazine, it causes least extrapyramidal side effect. I would like to mention you here that there is a drug which also comes under the phenothiazine. Its name is haloperidol. It causes very high extrapyramidal side effect. Similarly, atypical antipsychotics, I will let you know its example later on. It causes very low extrapyramidal side effects. But what will you do if extrapyramidal side effect appears? We have option. We will use phenothiazine drugs which have to be used for the management of schizophrenic patient. Side by side, we will use the benztropine, that is the antimuscarinic agent, for the management of extrapyramidal side effect. So this is all about point number one. Point number two is about the just value of ECT. ECT is electrical conversion therapy. It's a you can say will send electrical signals in the brain that causes brief surge, and the point here is that therapeutic value of ECG is due to conversion itself. So ECT has a therapeutic value in this situation of schizophrenia. Point number three is about the traveled dyskinesia. Traveled dyskinesia is a condition when facial muscle movement happens out of automatically or out of our control. It is defined under the traveled dyskinesia, and it is due to the excessive block of dopaminergic receptor. So traveled dyskinesia is basically the side effect of phenothiazine, and phenothiazine is a you can say all typical and atypical antipsychotic drugs. Side effect is defined as one of its side effect is just like extrapyramidal side effect. This travel dyskinesia is also their side effect. Point number four is about ADR. Antipsychotic drugs has autonomic nervous system related ADRs, like it causes antimuscarinic effect. It has central nervous system related ADRs. It causes dopaminergic receptor blockers, and it has endocrine related side effects, which causes like dopamine blocker, like prolactinemia, and point number four is about histaminergic and serotonergic block. Possibly, it causes weight gain. So it has autonomic nervous system side effect, central nervous system side effect, and endocrine related side effect, and histaminergic and serotonergic related side effect. So I think you would easily get it that wherever the muscarinic receptors are, or wherever the dopaminergic receptor, it wherever the histaminergic or serotonergic receptor, you can easily define its side effect. Where you can easily interpret what side effect can be or what profile can be. Point number five is, are you simply you can justify what whenever an interaction comes in it comes in front of you, you can easily justify this interaction. So let's move on. Point number five. Point number five is about the haloperidol. Haloperidol, as I told you, one of the example of phenothiazine drugs. Its dose is 2 to 60 mg per day. The point is that it shouldn't be taken with methyl dopa or alcohol. Why? Because as I told you that in CNS it blocks dopamine receptor, and similarly methyl dopa also block dopamine receptor. So there can be chances of synergism. On the other hand, alcohol increases the dopamine production and it decreases the dopamine production. So it also has an interaction. Point number seven is about the phenothiazine and its examples. Just I will mention a list of drugs which are the example of this comes into this class. That is the chlor, chloropromazine. Its dose is 100 to 1000 mg per day. Flufenazine. Its dose is 20 to 60 mg per day. Thiazine. Its dose is 2 to 120 mg per day. Haloperidol. Its dose is 2 to 60 mg per day. Thyridazine. Its dose is no. It's I don't have its dose. Secondly, example of its drugs that are commonly available in pharmaceutical preparation form in the pharmacies are, and it's also known as second generation antipsychotic. Its example is clozapam. It's also common under the phenothiazine class. Clozapine, its dose is 300 to 600 mg. Risperidone, its dose is 4 to 16 mg. Olanzapine, its dose is 10 to 30 mg, and quetiapine, its dose is 150 to 80 mg. 150 to 800 mg, and ziprasidone, its dose is 80 to 160 mg. This ziprasidone also causes QT prolongation. So be careful while prescribing. They are whenever you see this prescription in a hypertensive patient, then be careful about that because it causes QT prolongation. We will discuss later on. Aripiprazole, its dose is 10 to 30 mg. These are the examples comes under the phenothiazine class. And some other examples are just for the record I want to mention is triflupirazine, prefenazine, palperidine, sertinadol, and zotipidine and dexapinazole and cariprozine. Brixapiprazole and cariprozine. Sorry for the wrong pronunciation. This was the example of just the example which comes under the phenothiazine class. Point number 8 is about you can say that most first generation antipsychotic drugs except thioridazone have strong anti-emetic effect. This is the point. Similarly, you can say thioridazone also don't have the you can say thyroidazole as drug least extrapyramidal side effect or no extrapyramidal side effect. Similarly, it also have you can say that it don't have the antiemetic effects. So most first generation antipsychotic except thyroidazone have a strong antiemetic effect. Like all drugs blocks dopamine receptors centrally in chemotherapeutic trigger zone as well as periphery on the stomach, and through this way it controls the emesis or vomiting effect of the this vomiting effect. You can say it carry out its anti-emetic effect. So this was all about the schizophrenia. So let's move on next point. Here is a point which I don't have its reference. I tried my best to search, but I don't find any reference. It's a comparative anti-emetic effect of chlorpromazine that also comes under the class of phenothiazine and promethazine and fluperazine. The point here is that chlorperazine is most has higher antiemetic effect compared to prothiazine, and chlorothiazine has higher antiemetic effect compared to fluperazine. So just you go and counter check my this point because I don't have its reference. So next point is about the haloperidol. Haloperidol, as I told you, this comes under the phenothiazine class. It is contraindicated with the methyl dopa, alpha methyl dopa, because it causes life-threatening reaction. No, you have to again go back towards the ADR, which I told you about. That haloperidol in CNS blocks dopamine, and methyl dopa also blocks dopamine, and similar to methyl dopa, and the drug example is the gonathiidine. It's also an antihypertensive drug, and these blocks methyl dopa. So once you are using with haloperidol, it causes synergistic effect, so it can cause us life-threatening condition or life-threatening reaction. This is the most appropriate word. Next point is about the flufenazine. Its dose is its you can say in formulation is IM formulation, intramuscular formulation in oil and oil paste injection. This is just about relevant to pharmaceutical point. Point number next is about the again I told you dropinidol and butyrophenone adjunctive. These are two phenothiazine drugs. That example is dropinidol and butyrophenone. It is in combination this use in anesthesia. Whenever we talk about anesthesia, we will discuss about this drug again. So just for a reminder, keep in your mind that dropinidol and butyrophenone use in anesthesia. Next point is about the you can say pre-surgical apprehension. Pre-surgical apprehension is a patient when patient is about to go in a surgery, he feels anxiety. This anxiety is defined as pre-surgical apprehension. It is relieved by chloropromazine, and its dose is 100 to 1000 mg, and it is given in IV long duration. It's long duration depot formation because it's an oil-based injection. So chlorpromazine is used for pre-surgical apprehension. Point number next, I have already discussed about the extrapyramidal side effect, that is use of antimuscarinic as well as phenothiazine combination for the management of extrapyramidal side effect. Point number 6 is about the antidote. First, you can see there are some antidotes like 1 hour before, like chlorpromazine shouldn't be used in combination with antacid, and antacid either should be given 1 hour before or 2 hour later while taking the chlorpromazine. Point number 7 is about the aluminum hydroxide is contraindicated with promethazine. Okay. Point number next is about the exactly it's next about the all phenothiazine have extrapyramidal side effect except thioridazone. As I told you before, that thioridazone don't have extrapyramidal or least extrapyramidal side effect. Side by side, it don't have antiemetic effect. so it can be part of MCQ question. Point number no, sorry point next point is about the quitapine, and quitapine blocks the 5-HT exactly. Quitapine blocks the 5-HTT receptor, and its dose is 150 to 800 mg per day. Next is about the fluofinazine. Its formulation. It's also found in the formulation of interim IM formulation. And next point number 13. This is technical point. That is the neuroleptic malignant syndrome. This is a syndrome that antipsychotic drug neurogenic emergence. It's yes, exactly neuroleptic malignant syndrome. It's antipsychotic drug neurogenic emergency and mental status changes, rigidity, fever, and it's a side effect of antipsychotic drugs. This is defined as neuroleptic malignant syndrome. What happens in this? In this, patient feel mental disturbance, rigidity, fever, and you can say dysautonomia. Autonomic function is absolutely is vastly affected by this side effect. So what's the treatment option, and why do it happen? It happens due to excessively and rapidly block of post synaptic dopaminergic receptors. So we have three options for its the management. Number one is the use of number one is the anti-Parkinson drugs. We will use anti-Parkinson drug. Number two, muscle relaxants like diazepam and dentroline. These, and number three is dopamine agonist, bromocriptine. Because as you know that due to excessive block of dopamine receptor, it happens. So we will use excessive dopamine for its management. Side by side, we will use anti-Parkinson drugs, as well as we will use muscle relaxants for its management. In the example is diazepam and dentroline. And secondly, once this neuroleptic malignant syndrome is being cured, then we will switch our class for the management of schizophrenia to atypical antipsychotic drugs. And example of atypical antipsychotic drugs are aripiprazole, quetiapine, olanzapine, risperidone, and acinapine. So this was all about neuroleptic malignant syndrome. Point number 14 is again same, that haloperidol causes very high extrapyramidal side effect, and atypical antipsychotics causes very low extrapyramidal side effect. Point number 15 is about the travel dyskinesia. Travel dyskinesia, as we have talked about it, there's uncontrolled movement, facial movement, and it is relieved. It happens due to relative cholinergic deficiency. This is telling about here that travel dyskinesia. Let me tell you that video is going too long. I will discuss this point in the next video, because they also require a proper management option. But how we will manage this travel dyskinesia, it requires specific time. So video is going too long. I will let you know remaining part in the next video. So professionals, if you feel that this effort is effective or helpful for you, then please subscribe my channel, and I hope that you will ignore the pronunciation related mistake which I am doing while recording this video. It's because of two reasons. Number one is due to it's the first time that I am exposing myself in front of camera and recording this. Secondly, that syllabus is very lengthy, and our target is to compile it within 60 days. That's why I try my best to focus on extracting as much points as I can to provide you an effective data so that you can easily prepare for your exam. So stay healthy, stay tuned, and please subscribe my channel. Thank you.